Hello, everybody, and welcome to Ask Dr. Bob. This is where you get to ask me, Dr. Bob Gabbay, Harvard Medical School and the Joslin Diabetes Center, and former Chief Scientific and Medical Officer at the American Diabetes Association, your questions around diabetes and as we'll talk about obesity. Um, for those of you that are regular viewers of this program, you know that we take a topic each month and sort of try to dive deep into it. This month, it is the GLP1s, the GLPs, the incretins. They're called by a variety of different things, and we'll talk about that in a moment. Um, for those of you that are new, welcome, and returning visitors, hey, great to have you here. We have a lot to cover, and everyone has sent me a lot of great questions, so we're going to dive right in. Um, if you enjoy the program, please tell your friends and loved ones, and let's jump in. Um, the first question is really, sort of level setting is what are the GLP-1s? What is GLP? Well, GLP stands for glucagon-like polypeptide or peptide 1. Not a very creative name, but essentially it's a natural hormone that your body produces mainly when you eat. It's released by the intestines and it has a bunch of different effects in the body. Uh, so it's a natural hormone, and the discovery of its use and the first drug approved that was a GLP-1 was actually 20 years ago this year. So it's been around for a while. The natural hormone lasts only a matter of minutes, and so to be able to make it last longer, they had to discover a way to let the hormone act longer and not be destroyed or degraded quickly. And that clue actually came from the Gila monster, a bizarre looking lizard. You should look up the photo, it's a bit gross. But in any case, they isolated from the saliva of the Gila monster a long acting GLP-1. And that was the first GLP that came on the market 20 years ago. So you may know these drugs as semaglutide, or more famously, Ozempic or Wegovy. Uh, those are the largest sellers of these kind of drug, and they're very popular, and we'll talk about them. There's also a second important drug to know, and that's tirzepatide, also known as Mounjaro or a Zepbound. Um, and that medication is a GLP-1 plus a second hormone, GIP. So it's a combination of two hormones. That second hormone, GIP, gastric inhibitory polypeptide, uh, adds some additional effects and mainly a bit more weight loss. So those are the two most common ones. But there's a series of older ones that you may be familiar with and have heard about: Trulicity, Victoza, Trulicity, Victoza, Byetta. Um, those medications can still be very helpful for people with diabetes. Uh, they don't have the same effect on weight. They only have a smaller effect on weight. So the two main ones are really the ones that have the big weight effect. So, the next logical question, and again, thank you all for sending in your questions. How do these drugs work? Well, they work through three mechanisms, three different ways. So, the first one is particularly for people with diabetes, they help the body make extra insulin. And that extra insulin after a meal helps to lower blood glucose and basically lower the improve A1 hemoglobin A1C and result in better glucose control for people with diabetes. But the second way is it slows the emptying of the stomach. And so because of that, you tend to feel a bit more full because your stomach's not emptying and you eat less. And that's part of the weight loss effect. So that's number two. Number three is it acts also on the brain in the hunger centers and the reward for eating food that makes us want to keep eating sometimes. And it sort of works there as well to reduce appetite and sometimes what's called food noise. So three effects. One, stimulating insulin secretion for people with diabetes and lowering blood glucose. Two, delaying the emptying of the stomach so you feel more full. And three, acting on the brain in terms of appetite. Okay, so um, what's the difference? And this is a good question. I hear this a lot from my patients. What's the difference between Ozempic and Wegovy? Well, yeah, actually, they're the exact same drug, semaglutide, exactly the same drug. They're just different doses and different indications. So, indications, what that is that the FDA, when they approve a drug, they approve a drug for a specific use. Ozempic is the drug for people with diabetes. It's approved for people with diabetes, and it comes in 0.25, 0.5, 1 milligram, 2 milligram doses. Wegovy is the same drug, semaglutide, approved for obesity. And there, the dose is 2.4 milligrams. So it's a higher dose of the same drug in essence. What about, as long as we're talking about this, what's the difference between Mounjaro and Zepbound? Same thing, Mounjaro for people with diabetes, Zepbound same drug, tirzepatide, just indicated for people with obesity. So sometimes insurance may cover one if you have diabetes, but the other if you have obesity, and they're pretty much the equivalent, in within that class. Okay, moving right along. Um, what do these drugs do? What do they treat? Well, um, they all started as drugs for people living with diabetes, and they help control blood glucose for people with diabetes, uh, and then found to be very effective for people living with obesity as well. But what makes these drugs so exciting and why they've really changed the landscape of treatment is not only do they do that, but they also impact other things. And number one on that list is cardiovascular disease. These drugs lower the risk of cardiovascular disease, and that's what's made them really super important because certainly for people with diabetes, the number one cause of death is heart disease, and these drugs lower the risk of heart disease. Um, it also helps to protect the kidneys, particularly for people with diabetes. And now we're seeing other effects, including sleep apnea. A condition that we didn't have any medical treatment. The only treatment was really wearing a CPAP mask that not everybody tolerates. So it also has an effect there. And I think we'll leave for part two of this Ask Dr. Bob to talk about all the other potential things that these medications can do. So I mentioned in my original post that up to 20% of American adults have tried a GLP-1 drug. That's, and when I say GLP-1, I mean GLP-1 or the combination drug, GLP and GIP. Uh, so 20% of people have tried this medication, yet at the end of a year, less than half are still taking it. Hmm. So why is that? Well, we're not 100% sure, but there are probably four reasons, I think that explain this. Um, so why do people stop the medication? First is cost. They're very expensive medications. They're not often covered by insurance or only partially covered by insurance, and that is a big factor. And insurance coverage is changing. Many of you may see this month in January that there are new rules, and it may be less covered than it was. So what's happened around that has been this idea of compounding. So what is compounded? Let me just tell you a little bit about that because it's pretty popular, and it's estimated that almost 20% of people that are taking a GLP-1 like drug are using a compounded version. That's quite a lot. So compounding was allowed by the FDA for sort of the second reason why people drop off the drug, and that is that the supply is limited. It's hard to get it. Any of you that have been taking this drug, you go to your pharmacy and sometimes they say, oh, sorry, we ran out. You've got to shop around. So when there's a scarcity like that, the FDA allows compounding to occur. And the important thing to know about compounding is there's really sort of two different types of compounders. Um, One are very large manufacturing. So what is compounding for starts is that it is someone other than the original manufacturer making the medication. So you're getting it from another source, not the manufacturers and the discoverers of the drug, which, for the two main ones is Novo Nordisk and Eli Lilly. So when you're getting a compounded drug, some other pharmacy is making it. It could either be a larger pharmacy that is federally regulated by the FDA and has some oversight by the FDA. And how much oversight we could debate, but they're larger producers. Uh, and those are 504B pharmacies. The B is the important thing to remember. Um, and all factors being equal, they're probably a safer choice because they're larger, they do it in bulk, they're regulated federally. The small pharmacies that are for the 503As, they're sort of mom and pop pharmacies and probably riskier places to get your compounded medication. So, all our factors being equal, if you're going to use a compounder, you probably want to ask, is this a 504B pharmacy? This is probably better. Ask for purity studies. Some compounders will actually document the purity of what they have. That said, uh, buyer beware because there have been all sorts of reports of counterfeit GLP-1s on the market, bad things happening. It's hard to know. It's a very murky area. Ideally, getting your medications the way you get all of your other medications, typically through the manufacturers, is the safest. And what's going to happen about the cost of these medications? Well, there is this big pipeline of new medications that are being looked at, and we'll save that topic for next time because there's lots to talk about there. Um, so that's the number one reason I think, or one of the big reasons why people stop medication is the cost. Number two is supply. The third is side effects. And the biggest side effect is nausea and vomiting. That's the most common. And you can reduce the risk of that by starting at a very low dose. And that's what your prescriber should be doing, starting you at the lowest dose. You've got to be on that low dose for a month before you increase the dose to the next level, and then another month, and then gradually increasing. If you do that, most people tolerate it, but a couple of things that you can do to reduce the side effects. Um, I said that the drug works by slowing the emptying of the stomach, and so if you eat quickly, you can get overly full, and then your brain catches up, and you're like, oh, can't believe how much I've ate, and start feeling nausea and potentially vomit. So what I often tell my patients is, if you're going to sit down to a meal, eat half of it and stop. Um, Wait 5 minutes, let your brain catch up. You might feel full at that point and not need to eat the other half. If you're still hungry, okay, eat the rest of it, but that can avoid some of the problem. So cost, supply, side effects, and then the fourth one a reason I think people stop is it doesn't work. And it doesn't work for everyone. So that is true. But what I find really common is sort of false expectations. So Typically, these medications can result in, and I'm talking about the two main ones, semaglutide and tirzepatide. Uh, they can result in somewhere between 15% for the Ozempic class of drugs, and 20% weight loss for the Zepbound class of drugs, a little bit more potent. But it takes several months. You tend not to lose any weight in the first month or two. So there are many people that take the drug for a couple of months and they say, "Hey, I didn't lose any weight. This stuff isn't working," and they stop. If you're wanting to see the effect, you probably need to give it 6 months to really see the benefit. So we'll take another quick question and then sort of move on. Um, and that is, are these medications safe? Well, every medication has side effects. Uh, the good news here is this class of medications, GLP-1, have been around for 20 years, so we know a lot about them. Nausea, vomiting is the most common side effect. We talked a little bit about that and what to do. And then the warnings are for a rare form of thyroid cancer. This was something seen early on with these medications in animals. It hasn't really been reported much in humans, despite the 20 years of study, but it's still a warning. And therefore, if you have a rare form of thyroid cancer, not the common kind, but a rare form called medullary thyroid cancer, which is really an unusual form, you shouldn't take the drug. Second, uh, sort of thing to watch out for that's been reported is pancreatitis. Maybe a slight increase in pancreatitis. If you have a history of that, shouldn't be on the medication. Uh, People with obesity and or diabetes have an increased risk of pancreatitis too. So, got to factor that in. So that's the other one. The one I want to spend the most time on is muscle wasting. So any kind of weight loss uh, will result in some loss of what's called lean body mass, which is muscle mass. We want to keep our muscle mass. It's important. Uh, and when you lose weight, you tend to lose muscle mass. And these medications result in some muscle loss, but there's something you can do about it. And that's the message I want to make sure I talk about. And so what can you do? One is using your muscles, something, what's called strength training, any kind of lifting weights. You're like, "I'm not a weightlifter." You don't need to be a weightlifter. Any kind of thing that's using your muscles will help reduce the amount of weight loss. It could be uh, taking a can and doing bicep curls with it. That may be enough weight for you. It could be going to the gym and doing some strength training. It could be some kind of calisthenics. There are lots of ways things that you can find on YouTube of exercises that are around strength training. Again, like any exercise, start slow, use a low weight, gradually build up, but that can reduce the weight loss. And then the other important thing that I think is not talked about enough is making sure you eat enough protein. So, you know, people on these medications eat less, and it's easy to not end up eating enough protein. And protein is important for muscle. So, how much protein do you need? Well, the recommendations are zero point 0.8 grams per kilogram of body weight, but how do we convert that? Here's the number you need to know: 0.36 uh, grams of protein per pound of your weight. So whatever your weight is in pounds, multiply it times 0.36. Multiply it by 0.36. Pull out your calculator on your phone or whatever and figure out how much uh, protein you need in a day, and track your protein for a few days and see, are you getting that much protein? Now, if you're over 60, you need more protein because as we age, we naturally tend to lose muscle mass. So that is zero point 0.7 grams of protein per pound of body weight. So your body weight times zero point 0.7. Do that calculation, track how much protein you're eating over the course of a week and see if you're meeting that. Many people need to be a bit more mindful of their protein. So we've covered a lot of ground here, and I think we're gonna do a part two because I've gotten so many questions, including what's the pipeline of new drugs out there in this class. There's a lot of excitement there. What about people with type 1 diabetes? Send your questions to Ask Dr. Bob at drbobgabay.com. That's askdrbob at drbobgabay.com. Glad to answer all of them. Some of the questions we didn't get to, we'll try to do next time. If you enjoy this program, uh, tell your friends and loved ones. I'm here for you, and I just love doing this. So thank you for joining, and see you next time. Be well.